Please, Mr. Proactor, unmute and start your video. You are on the floor.
Yeah. Thank you.
Excuses for the delay, but it seems we lost our proactor at the moment. 1 second. On behalf of the prorector, I have to announce that he is coming back, but that the candidate can start with the public defense, so starting the presentation. The floor is to the candidate.
Dear prorector, member of the Corona, my family, friends, and audience, thank you so much for giving me the opportunity to present my thesis today. I'm going to share my screen. So my thesis title is called In-Depth Clinical Investigations over Cardiac Tumors in Adult Patients. Background: primary cardiac tumors are rare. They constitute diagnostic and therapeutic challenge. Atrial myxoma is the most frequent primary cardiac tumor in adults, while atrial myxoma is the most frequent primary cardiac tumor in adults, while rhabdomyosarcoma predominates in children. Mature primary malignant cardiac tumors are sarcomas. Surgery represents an integral therapeutic modality. Advances in surgery and minimally invasive approaches worth investigations in short and long-term outcomes. Research outlines: we included 7 articles related to cardiac tumors, 2 meta-analyses, and 5 large databases related articles from United States National Cancer Database and Surveillance Epidemiology and End Result Database. The 2 meta-analyses include 1 single-arm meta-analysis on cardiac tumor prevalence, in which we used pooled event rate and incidence rate as effect estimates. The other one was pairwise meta-analysis in which, on minimally invasive versus median sternotomy approaches, we used incidence rate ratio, standardized mean difference, and risk difference as effect estimates. The 5 large databases related articles were on sex differences, insurance effect, octogenarians outcome, angiosarcoma outcomes, geographic variation. In thesis chapter 2, we aim to analyze cardiac tumor prevalence and mortality. The 1,226 retrieved articles, 74 were included in our study with a total number of patients of 8,849 patients. The mean follow-up was 2.27 years. The mean age was 42.9 years. 55% of the patients were females. Total number of 7,484 were benign primary malignant cardiac tumors. Among them, 5,140 were myxoma, 862 were malignant primary cardiac tumor, and 355 cases were secondary cardiac tumors. The prevalence of primary malignant cardiac tumors among primary cardiac tumors was 10.83%. It was lower in South America, as the prevalence was 5.80%. The prevalence of heart transplantation among all patients was 2.45%. The pooled short-term mortality was 5.9%. The incidence rate of late mortality was 2.55% in all cardiac tumor, 4.79% in benign cardiac tumors, and 14.77% in primary malignant cardiac tumors. On meta-regression, the annual volume of cardiac tumor cases per center was the only predictor of lower early mortality. Primary malignant cardiac tumor represents the minority of primary cardiac tumor, about 10%, and they have a higher prevalence in Europe and North America. Survival is higher in benign pathology and is significantly improved by treatment in specialized high-volume centers. Approximately 2% of the patients with cardiac tumors undergo heart transplantation. In thesis chapter 3, we conducted a systematic review and meta-analysis to analyze the minimally invasive versus median sternotomy approach to primary cardiac tumors. 11 studies with 653 subjects, among them 294 minimally invasive and 359 median sternotomy were included. There were no significant difference in terms of late mortality, relapses, and redo surgery. Minimally invasive approach resulted in prolonged operative time, but that didn't influence the clinical outcomes. Tumor size didn't significantly differ between groups. Both approaches were associated with excellent early and late outcomes, with acceptable survival rate and low incidence of recurrences. This study confirmed that cardiac tumor may be approached safely and radically with minimally invasive approach. This is chapter 4. The National Cancer Database was analyzed to identify 6 differences in primary malignant cardiac tumors. 736 patients were included. Median age was 52. Female represented 47.8%. Most of the cases were high grade. About 60% underwent surgery. Angiosarcoma represented 43%, while fibrosarcoma and leiomyosarcoma, both of them represented 5.2% of the pathology. Multivariate Cox regression showed that factors associated with lower survival were higher income, higher comorbidity index, angiosarcoma, and stage 3 and 4. While factors associated with better survival were recent year of diagnosis, use of surgery, or chemotherapy. Among the surgery subset, factors associated with lower survival were advanced age, higher income, higher comorbidity index, angiosarcoma, and stage 3 and 4. While factors associated with better survival were private insurance, recent year of diagnosis. No difference was seen between males and females in 30 days mortality, late mortality either in the entire cohort or in different subgroups. In thesis chapter 5, we analyzed the National Cancer Database to identify association between insurance status and survival among patients with primary malignant cardiac tumors. We included 699 patients with a median of 52 years and 47.8% were women. 58.9% had private insurance, 34.8% had governmental insurance, 6.3% were uninsured. The overall operative mortality was 8.5%. 11.1% were operative mortality was 11.1% among the uninsured, 2.6% among Medicaid, 13.9% among the Medicare, 7% among those with private insurance. The median follow-up time was 64.1 months. Factors associated with lower survival were higher morbidity index, angiosarcoma, stage 3 and 4 cancer, while factors associated with better survival were private insurance, recent year of diagnosis, and treatment by surgery and chemotherapy. In thesis chapter 6, we analyzed the National Cancer Database to identify short and long-term mortality outcomes of octogenarians with primary malignant cardiac tumors. We included 736 patients. Median age was 52 years. There were 9.8 septuagenarians and 5.9 octogenarians. Overall, there were 47.8% females, almost 80% were white, less than 10% were uninsured, while 56% had private insurance and 34% had governmental insurance. Predictor of 30-day mortality among surgical cohort included octogenarian and those with higher comorbidity. On multivariable Cox regression analysis, the predictor of late mortality included octogenarian, governmental insurance, higher comorbidity, Charles and Deo grade 2 and 3, earlier year of diagnosis, angiosarcoma stage 3 and 4, and absence of surgery or chemotherapy. With increasing age, patient presented a more significant comorbidity burden compared to younger one and were treated more conservatively. Early and late survival outcomes progressively declined with advanced age. Surgery and chemotherapy were associated with longer survival benefit, but not radiotherapy. In thesis chapter 7, the National Cancer Database was analyzed to identify outcomes of surgery in cardiac angiosarcoma. Angiosarcoma was identified in 294 patients. Median age was 48 years. Female represented 40%. Surgery was done in 44, while 17.7 received no treatment. Multivariable Cox regression predictor of late mortality were earlier year of diagnosis, advanced stage, and absence of surgery and chemotherapy utilization. Overall survival among surgery alone versus surgery and others was 2.8 versus 17.2 months respectively. Median overall survival among surgery and chemotherapy versus chemoradiation was 18.4 versus 10.4 months. Median overall survival among no treatment, unimodality treatment, bimodality, and trimodality was 1.2, 8.2, 15.8, and 13.9 respectively. So angiosarcoma has poor overall survival, while double robust technique confirmed the importance of surgery utilization. Our study found that it is not the main utilized modality. In thesis chapter 8, we analyzed the United States surveillance, epidemiology, and end results database to identify geographic variation in primary malignant cardiac tumor and their outcomes. The median overall survival was 11, 21, 13, and 11 months for Midwest, Northeast, South, and West region respectively. 5-year survival was 22, 25, 14, and 17% respectively. The South region had significant higher proportion of blood patients, sarcoma, and lower income in comparison to Northeast region. While univariate analysis revealed that patients in South areas had worse survival compared to other geographic areas, geographic disparity in survival was nullified in multivariate analysis. Multivariate Cox regression predictor of late mortality were advanced age, recent year of diagnosis with hazard ratio less than 1, carcinoma, sarcoma with hazard ratio more than 1, localized and regional stage, surgery, and chemotherapy. In conclusion, primary malignant cardiac tumor represents the minority of primary cardiac tumors, about 10%. Survival is significantly improved by treatment in specialized high-volume centers. Surgery and chemotherapy, but not radiotherapy, were associated with longer survival benefits. Advanced stage, higher comorbidity index, angiosarcoma histology, stage 3 and 4, were associated with shorter survival. No difference was seen between males and females in different outcomes. No difference was seen between different US geographic regions in different outcomes. Thank you for your attention. And I'm giving the floor back to the prorector.
Yeah, apparently. Okay, then we start now with the questioning of you, the candidate. And the opposition will be opened by Professor Biesen. He is a professor of experimental vascular pathology at this university. He was chairing the assessment committee of the manuscript. Professor Biesen.
Okay, thank you. Dear candidate, congratulations on your thesis. And I would also like to extend my congratulations to the supervision team, both here in Maastricht and at Cornell University. It's an impressive piece of work. And although my background is on vascular pathology, not on oncology, let alone cardio-oncology, I did really recognize the high quality of your thesis. So my congratulations on this. Now, I'm particularly interested in your investigations on potential sex differences in phenotypic manifestation and or prognosis of PMCT. So my first question, I make it pretty simple for you because I'm a layman. So I was wondering what led you to investigate sex as a modifier, a potential modifier of PMCT. I know that of course, sex-related hormone balances, you have sex-related differences in immune responses that could underlie a higher propensity to develop PMCT. Were there any specific reasons why you sort of took this modifier into investigation?
Dear esteemed proponent, thank you so much for your kind words. Regarding your question, it's really a valuable one. It came in line with my prior investigation of sex difference among cancer in general. I worked before in malignant pleural mesothelioma, and also in Cornell we worked on sex difference in coronary artery bypass graft. We found some differences between them. So, for example, in mesothelioma, we found that there was aggressive stages in males, while finally we didn't find difference in survival. In coronary artery bypass graft, we found that there is a higher perioperative mortality in females, and we have a series of investigation for this one. So it came to my mind, why not to investigate the difference in sex, such sex difference in cardiac tumor. As you know, there is also hormonal difference, with some hormone may express like may be responsive to like some hormone modifier like tamoxifen or something like this. That's why it's like a kind of searching for any difference in survival that may contribute to further or any difference in future treatment.
Okay, thank you. I'm contented with this answer. Now, a bit related to that, unfortunately, you did not see, or fortunately, actually, you did not see any differences in both in incidence as well as in prognosis, and especially the latter is, I think, encouraging news. On the other hand, I was a bit surprised to see that if you look at the phenotypes of PMCT in women versus men, you see a higher incidence of angiosarcoma in men, and that was generally sort of associated with a worse prognosis. Nevertheless, you see sort of no effects at all. Do we have any explanation for this seeming paradox, or would it be are differences masked by maybe an underpowered study, although your study is already pretty highly powered as such?
Thank you for your question, esteemed proponent. So I see your points, and I totally respect that. But as I mentioned earlier, in the same issue with my prior study in mesothelioma, I found aggressive stage in males. However, this didn't translate into survival benefit or survival disadvantage. The same here. I see that angiosarcoma was in a higher percentage in males, but this didn't translate. The question regarding the power, I didn't calculate it in this subset in particular, but it's worth further investigation. So,
and what direction would you think then, the further investigation? Because this is probably the highest powered cohort around.
Yeah, so till now, maybe in the future, with increasing number of participants in those large database, we can reassess such group, because as you can see in one of my chapters, I investigated angiosarcoma only, and in that chapter also I didn't find the difference between both of them, males and females.
Okay, now thank you for your answers, and I give the word back to the pro-rector.
Thank you, sir.
Thank you, Professor Biesen. Then the opposition, the questioning or the discussion will be continued by Professor De Reuscher. He's from the Department of Radiation, Oncology and Reproduction, and today he's acting as our secretary of this board. Professor De Reuscher.
Thank you very much, Mr. Pro-Rector. And first of all, also from my side, I want to congratulate you and your whole team, of course, and also your family, because also for the family, most of the time a PhD is quite a heavy burden for this excellent work. But I'm here to ask you some questions, of course. And I want to focus on angiosarcoma. And you say that angiosarcoma, the best way to treat it is with some surgery in there, but also some systemic treatment. And of course, you acknowledge also that there is a bias towards non-surgical patients, of course, because it's also a prognostic factor. But what do you think is the future? So if you are sitting in front of a patient with angiosarcoma, you would think, let's say 5 or 10 years ahead, what do you think would be the best treatment of those patients?
Dear esteemed proponent, thank you for your question and kind words. So regarding angiosarcoma or sarcoma in general, this is one of the continuously changing fields, especially in the era of targeted therapy and immunotherapy, for which we have to be in a continuous up-to-date search for the best treatment. And we have to respect tumor boards and multidisciplinary team assessment, because every now and then new clinical trial will get into the spectrum of treatment, and any improvement in such modality worth further assessment or further application on our treatment. As you know, we are in the era of personalized treatment and molecular and assessment of molecular genetics and personalized treatment. I in my study, as you saw, was in single modality, for example, only surgery was associated with dismal survival. However, when we combined either bimodality or trimodality, we found much better outcome. So that's why we have to work together as a specialized team in treating cardiac tumor, especially those sarcoma patients, especially they represent a high percentage of the pathology, the cardiac tumor pathology.
Indeed, and if you think about the future, you mentioned already some molecular changes. What do you think would be the one of the possibilities, of course, to also improve the systemic treatment of those patients? Because you mentioned throughout your whole thesis that obviously most patients fail on distant sites, or, as Celie says, also my experience, have from the beginning distant metastasis. What would your solution then be? How do you envisage the systemic treatment, and of course the integration of the systemic treatment with the local treatment?
So I believe this, as I mentioned, this is like a multidisciplinary issue, and as maybe as a future work, I will be included in some lab work related to genetics for angiosarcoma in particular, regarding some vascular or like anti-vascular, vascular endothelial growth factor modifier or inhibitors, maybe of use in such case. But we need an input from our colleagues in medical oncology and especially on targeted therapy for this treatment.
And sorry to interrupt you, but how would you integrate this with surgery? Would you think about a concurrent approach? Would you think about an induction systemic treatment approach? And if so, how would you place then surgery? How to select those patients for the local treatment? Because you have in those patients also the need to have an effective local treatment as well. So would you think about induction systemic treatment and then surgery, or vice versa? And what would be your criteria to go for one strategy versus the other one?
Thank you for your question. So that's also depend on the stage that the patient is presenting in. And in general, for soft tissue sarcoma all over the body, if I extrapolate that if I extrapolated cardiac tumor from that, they found no difference in pre-operative versus post-operative intervention or systemic therapy or chemotherapy. However, it might decrease the size of the tumor with induction chemotherapy, but a combination chemotherapy is essential in angiosarcoma.
Thank you very much. I will give the word back to Mr. Pro-Rector to give the other opponents also sufficient time for the discussion.
Thank you, Professor De Reuscher. Then indeed we go now to Professor Stelzer. He's a professor of cardiothoracic surgery at Mount Sinai Hospital, New York, USA. He was a member of the assessment committee of the manuscript, whereas Professor Sterry is. Professor Stelzer, the floor is yours.
Thank you very much, and thank you, dear candidate, for this excellent and extensive review of a very uncommon but very lethal disease. I want to ask you a couple of questions about how far can you go in taking small numbers of patients and making conclusions about them. The one that comes to my mind specifically is in chapter 2, where you talk about the instance of transplantation. And there's a fairly small number of studies that you actually used for this. I think there were only 7 studies that were included, and the number of patients that were actually included with primary tumors was fairly small, especially the ones that were malignant tumors. And there is a little bit of a discrepancy between the abstract and the other part that you clarified nicely, that there had been a kind of popular belief that the incidence of secondary tumors was far greater than primary tumors. But I think you've made a very strong argument that this is really quite the same. Secondary and primary are about the same, about 9.9, 10%. So that's a good thing. But when it comes to actually transplanting the patients, The incidence of that it's a little bit confusing how many different plots you can do. You had 4 different ones in your figures at the end of that chapter that talked about how you could determine the outcomes in terms of these literally 5 patients with malignant cardiac tumors, and 6 more got added from just a couple of different centers that I can't figure out what they had, whether they had a non-malignant tumor or whether it was a secondary tumor. Maybe you could comment on how these techniques that you used could let you draw a statistically significant conclusion about the use of transplantation in this rare disease.
Dear opponent, thank you so much for your kind words and for your question. So regarding determination of heart transplantation as a treatment modality among cardiac tumors, I have to, at that time, I have to get like the prevalence in different way to get a proper estimate for the reader. So as you can see in my prior presentation, so the prevalence of heart transplantation for primary malignant cardiac tumor among primary malignant cardiac tumor was higher, 13.8%. That was derived by determination of 2 numbers, numerator and denominator. So I have to find the total number of patients who had heart transplantation and divide them by total number of patients with primary malignant cardiac tumor. And that's the number that I got. And that was reported only in 7 studies out of that big number of, initially was 74 studies, that was reported only in 7 studies. So, and after that, I moved to the prevalence of heart transplant for primary malignant cardiac tumor among total cardiac tumor that included also benign pathologies. And at that time, it was the lowest, 1.4%. The third one was prevalence of heart transplantation for primary malignant cardiac tumor among those with primary or secondary malignant cardiac tumor. It was 8.9. And the last one, the prevalence of heart transplantation among total cardiac tumors, it was 2.45 that I mentioned in my presentation. That's how I got those figures and those numbers.
So it's a small number of people, certainly. And,
sure.
It's interesting to give that perspective. Another perspective question that I wanted to ask you is when you're looking in the I believe it's chapter 8 with the SEER database and looking at the regional differences around the United States, and when you look specifically at where these came from, the studies came from a very small selected number of states.
Yes.
The Midwest one kind of jumped out at me because I come from the Midwest, but the only state you have represented at all is Iowa of 29 patients, and yet you have a very large number of patients in the Western region with a big state like San Francisco and all the big stuff out in California. You didn't include Texas, you didn't include New York in the other ones. And so I wonder whether there's a selection bias that comes in inherently when you have a database that has a small selection of states from those regions. How do you account for that? The statistics fool us there.
Dear esteemed proponent, thank you for your question. So it's basically, as you said, it's one of the limitations of our study. So I took the included states and divided them into those 4 groups based on the regions of the United States. I'm totally respecting your question, but as you know, every study has its own limitation, and I acknowledge that in my limitation section. But also, as you know, large database has many limitations. Some of them is some coding errors, but we tried our best to be accurate and to be transparent in our derived conclusion and derived number. And also, as you said, number numbers are low in certain category, but that's one of the limitations. I totally agree.
Thank you. And my time is up. I yield the floor back to the pro-rector. Thank you.
Thank you, Professor Stelzer. Then the opposition will be contained with Professor Nagla Abdelkarim. She's professor in hematology and oncology at the Innova Shar Cancer Institute in Virginia. She was also a member of the Manuscript Assessment Committee. Professor Karim of Nagla, or whatever I have to call you.
Thank you. Dear colleague, congratulations on your work. I would like to address a few questions, and I'll keep it brief, and start with the first question. Would you see a role of management for oligometastatic disease in patients with, metastatic lesions involving the cardiac tissue? Especially taking into consideration the multidisciplinary approach.
Dear esteemed proponent, thank you for such intelligent question. So, as you know, as I mentioned, cardiac tumor represent a rare disease, and it's always worth including the patient in a multidisciplinary discussion. Oligometastasis is a really challenging subgroup of patients, because if we are talking about poor prognosis disease, what about if we are facing a patient with oligometastasis? So that, as I said, that should be included in multimodality assessment. And the role of targeted therapy and immunotherapy should be investigated, or should be the discussion team or the tumor board should be up to date with the continuously updated treatment modality in such field. For example, for one of the studies that I read was about oligometastasis, single metastasis that was treated with BRAF inhibitor fumarafinib, and that was effective. However, the other treatment, the other patient prognosis was really bad. We have to consider if the primary treatment, the primary cancer was controlled or not. We have to consider the interval between the control for the primary and the presence of metastasis. Also, robotic, with the advances of minimally invasive technique, robotic surgery might come into play in this, in treatment of such metastasis. We have to respect the performance status of the patient, and if he can tolerate the systemic chemotherapy, the surgery, the kind of surgery, and or not. So it's like multifactorial assessment of the patient and the prognosis. If we are talking about sarcoma, it's really it really has a poor prognosis. So we have to be very, very cautious if we will proceed with metastatectomy in such cases, because we have to try systemic modality first. And that's it. So,
I mean, maybe to also add to that question as well, what would you see in the future for application of precision oncology in this arena? So yes, of course, systemic therapy, but if patient is well controlled on the systemic therapy and there's only one or two oligometastatic lesions, would you see a future for management of this within the cardiac tumors? And if maybe, you can answer this, and I can say the second question afterwards.
Yeah, indeed, I agree with that. So using targeted therapy and personalized therapy after molecular testing is important in such kinds of patients. And also some retrospective studies reported survival advantage with surgery in such cases. However, we really need to do like international database to include those patients and to keep monitoring of the outcomes and the treatment that was done for them.
Okay, brings us to my second question. When you mentioned in chapter 2, page 37, and in other chapters as well, about higher prevalence in Europe and North America, about the cardiac tumors, and 2% of those patients undergo heart transplant. So the first part of the question would be, what is the comparison between the different prevalences? When you mention its higher prevalence, if you have data about other areas of the world, and also about the criteria where you would recommend heart transplant.
Dear esteemed proponent, thank you for your question. So about the prevalence, the difference in prevalence in different geographic area or in different continents, that was one of the idea that came to our mind when we were investigating the prevalence. We noted the lower prevalence in North America and the higher prevalence in Europe and South America. That's maybe related to different factors. So some of them, and also putting in our mind that this is a rare disease. So some of them may be related to genetic difference. As you know, there is a syndrome called Carney syndrome, which is characterized by mutation in cyclic AMP related genes. And that was discovered by one of our senior colleagues in Cornell. That for that disease, it was associated with myxoma, familial myxoma. So that one, we don't know the difference in that genetic over different continents, but this is an example of genetic variability. Also, environmental factors such as chemical exposure to chemicals, exposure to radiation, that may also be considered. Other issues are advances in healthcare, access to healthcare, and advances in healthcare, recording the patient data and investigating the patient data. This is different among different continents. If we are dealing with aging population, there is a higher chance to get cancer discovery in them compared to patients who died early in like poor countries. So that may be some of the causes why there is variability in discovering in the prevalence of cardiac tumors. Also, just reporting, are those people from South America reporting their cases, or there is selection bias, or that's also may be considered as a cause for such variability. Regarding the last point of heart transplantation, I believe, what is the situation of heart transplantation in cardiac tumor? One of my colleagues did in Cornell did a comparison between cardiac tumor, heart transplantation for cardiac tumor versus heart transplantation for hypercardiomyopathy. For cardiac tumors, he found a difference of, the median survival was 2.5 years versus like 11 years in the other group. So we are talking about poor prognostic disease in general. It's worth to investigate the heart transplantation outcomes. However, he worked on International Society for Heart and Lung Transplantation database, and in that database there was no
Dr. Rahouma,
yeah.
Rahouma, sorry,
Yeah.
sorry to interrupt you, since Professor Karim does not do that, but I would like to ask you to finalize your answer in a brief period of time.
Yeah. So as I said, heart transplantation is is one of the modality, but it is worth to avoid it in advanced cases, especially angiosarcoma, as palliative treatment was giving comparable results.
Thank you very much. And back to our prorector. Thank you very much for your answers.
Thank you, Professor Karim. Then we continue the opposition by Professor Gelsomino. In the twin picture there, he is the right one, I think. Professor Gelsomino.
Yes, Gelsomino. Thank you, Mr. Prorector.
You are also vascular thoracic surgeon, cardiac surgeon?
Yes.
Correct?
Yeah, cardiac surgeon at Maastricht University. Thank you, Mr. Prorector. And first of all, let me join the other colleagues in congratulating the candidate for the great work. My first question is, I would like to go back to chapter 7 and to go back to angiosarcoma. Because Mr. Candidate, you have stated once more that angiosarcoma is a very dismissible and very poor prognosis. So we know very well that angiosarcoma is not, unfortunately, we don't have at the moment a reliable staging or grading system to guide us as surgeon. And then angiosarcoma is also not influenced by tumor grade margin or growth pattern. Okay. And also, we know it's been established that there is the difference between left and right side sarcoma, because the right are more invasive and they are worse prognosis. But the left sarcoma, they are more prone to left heart failure, and also they are less sensitive to chemotherapy. And finally, we know that they are not sensitive to either to neoadjuvant or adjuvant therapy. So my question is to the specialist. You are supposed to become the specialist of this very controversial issue. What is the take-home message for us as cardiac surgeons? So when is not worth anymore giving, so operating patient, giving surgical indication for patient? Because we know for other kind of, for instance, lung tumor, then we have more than a grade 3A with, is useless. But before this very worse prognosis, when is still worth operating patients? Thank you.
Thank you, dear esteemed proponent, for your question and your kind words. So, as you said, the angiosarcoma was associated with poor survival in general. However, in our multivariable model, we found that surgery and chemotherapy was associated with better outcome rather than radiotherapy. And also, we found that those who received more than one treatment modality was associated with better outcome. So, when it comes to the treatment of such cases, we have to assess the stage of the tumor, extent of the disease inside the heart, whether it invade other organs or not, and the performance status of the patient. It's worth to say that yes, we can operate on those patients as long as we are dealing with limited disease, because as you saw in chapter 7, there is giant difference between if we left the patient untreated versus those who received surgery. And also, and this may be one of the challenging that I found, why there is discrepancy between the offered treatment or the best available treatment and those who received no surgery. Because that was a question mark. Why the treatment in the United States, why surgery, even if surgery was offered, was associated with better outcome compared to no surgery, why it was not the best, or it was not offered. So I investigated that and I found that some patients refused treatment, it was not recommended. So that was what I found in my study. So again, such cases should be assessed in multimodality treatments. Surgery should be offered and be one of the integral part, including of up-to-date targeted therapy and immunotherapy and chemotherapy for sure, and radiotherapy. So multimodality treatment should be offered for such a patient.
Okay, thank you very much. I go quickly to the other question. From my experience, since I had experience with another PhD student with a very large database, with a single from a multicentric database from Europe on sarcoma, soft tissue sarcoma. And the experience was that soft tissue sarcoma are very often localized in multiple sites, and very often localized 2 or 3 different sites, and very often associated with the with metastasis, lung metastasis, or other or bone metastasis. My question is, based on your experience, what kind of a sarcoma, apart from the angiosarcoma, is more more associated with the multiple localization and with metastasis, secondary repetition, I mean?
So thank you, dear esteemed proponent. So in general, soft tissue sarcoma are associated with metastasis and advanced stage. That's much common than being a limited disease. So in dealing with, and as I mentioned in my work, rhabdomyosarcoma was the most common in childhood period, while angiosarcoma followed by fibrosarcoma and leiomyosarcoma was the most common pathologies. So indeed, we have to assess those patients for systemic manifestation or systemic mets before proceeding with treatment of cardiac tumor in particular.
Okay, thank you very much. I'll give the word back to the prorector, Mr. Prorector.
Thank you, Professor Trelzmini. Yeah, we have the possibility for 2 people still to question you. And that means that I ask Professor or Dr. Marrow to give also some opportunity to his fellow countryman from Parma to ask something. Is that possible to arrange it that way? If you check your logs. Professor Mauro, Dr. Di Mauro, cardiothoracic surgeon from this university.
Thank you, Mr. Prorector. Dear candidate, first let me congratulate for this interesting thesis. The cardiac tumors are not a common item of research in cardiac surgery, so I think your thesis may provide a good look, a good interesting point of view on the state of heart in this field. My first question is about the inverse relationship between the annual volume of each center and early mortality after surgery for cardiac tumors. So do you think we have to go to some hub center, some specialized center, cardiac center, to treat these tumors with high volume, with annual high volume?
Esteemed proponent, thank you so much for your kind words and for your valuable question. So, as you mentioned, and as I found in my work, there was a big difference between treating patient in low versus high volume, and that was established through subgroup analysis of annual cases done in each center. So we found that those cases, that centers that had 5 or more annual cases of cardiac tumor had perioperative mortality, which is less than, I believe, less than 2%, while cases who had lower than 5, while centers that had less than 5 had much higher perioperative mortality. That should direct us that we should put a minimum requirement for when we open a center of excellence or center for cardiac tumor treatment, surgical treatment, and also for the sake of the patient to get the best outcome, it's better to be directed to high volume center.
Thank you for your kind answer. And my last question is about the surgical approach. You compare the sternal median sternotomy with minimal invasive, and finding no difference between the 2 approaches. But I think this is mainly due to the presence in the primary tumors of myxoma, because otherwise, if you have a complex case of tumors clinically, I think median sternotomy is easier to visualize all the tumor and to treat it, to eradicate fully the tumor. This is my opinion. I want to know your opinion on the basis of your research. Thank you.
Thank you, esteemed proponent, for your question. So what you mentioned is really one of the important questions that came to our mind when we wrote the discussion for that paper. So as I mentioned in the discussion, that the group from Mayo Clinic, the majority of the included group of the included patients in that hospital were on benign tumors. However, they reported also in a subset that the outcome was comparable between those with primary malignant cardiac tumor, even though they mentioned it was a small sample size among the entire group. So I basically agree with your point. That should be on a larger scale. There should be a larger scale of primary malignant cardiac tumor assessment for median sternotomy versus the minimal invasive approach.
Thank you. I give you back, Mr. Prorector, the word.
Kind of you. Then we have indeed still the possibility for Professor Domenico Corradi from Parma, Italy, pathology department over there, to ask his questions and take part in the discussion. Professor Corradi.
Thank you very much, Mr. Prorector, for giving me the word. Dear candidate, first of all, I would like to congratulate you on your brilliant thesis, which has dealt with a major subject from a clinical and pathological point of view. I am a pathologist, and as a pathologist, I have a couple of questions, general questions on your contribution. My first question is on a diagnostic approach to cardiac tumors. In your opinion, can a merely clinical diagnostic preoperatory approach to cardiac tumors replace the utility of a preoperatory cardiac biopsy? In other words, in this case, preoperatively, is a biopsy avoidable or not, in your opinion?
Dear esteemed proponent, thank you so much for your kind words and for your question. So your question is true for some cases. We don't need pathological assessment. For example, if we found like a small pedicle tumor in the left atrium, mostly it will be myxoma. Meaning that we should take into consideration the output from imaging modality, echo, and magnetic resonance imaging, cardiac MRI, because many of those cardiac tumors has characteristic picture. However, in some of them we cannot judge the pathology based on the criteria. In such cases, we have to take a biopsy. For example, for fibroblastoma, usually it is available. It is seen on the valve, as you can see in the cover page. For angiosarcoma, it's common on the right atrium, in the atrioventricular groove, which means that we have to first of all respect the location of the tumor, respect the age of the patient, which may give us a lot of conclusion on the diagnosis. Also, the amount of calcification, the heterogeneity, presence of necrosis and hemorrhage that may be identified through heterogeneity in MRI or in echo, heterogeneity of the tumor. That's how I see that point.
Yes, I agree with you. This is our approach too. Yes, I agree. Thank you. My second question is that we all know that there is no specific TNM staging system for cardiac tumors, so that these neoplasms are often staged, for example, by using the soft tissue staging system, which by definition is non-size specific, but dimension specific, for example. Therefore, I would like to know your opinion on this lack, and whether would it be sensible, reliable to organize a sort of task force and a related writing group, which is be able to propose a reliable and tailored staging system for cardiac tumors. Thank you.
Thank you so much, dear esteemed proponent, for such really awesome idea. Because yes, there is no staging system for cardiac tumor, and I agree with you. I totally agree with you that we need such.
Yes, dear candidate, you may very briefly finalize your answer.
Yeah.
If you wish.
Yeah, we need such a staging system, and for that we need the task force and the international collaboration to establish such a staging system. Thank you.
Thank you. Congratulations.
The possibility for the questioning is and your defense is over now. We are withdrawing to a more private session, and I ask you and the possible viewers via live stream to await our return on this main session panel. And that is so far now we are transferred to that room, I suppose.
Thank you, sir.
Yes, dear candidate, the committee has discussed the quality of your thesis and the quality of your defense. And based on its positive verdict on both, and in view of the former qualifications, academic qualifications you obtained already, it has decided to grant you the doctor's title. Professor Rahouma is authorized by us to confer upon you this academic distinction. The floor is to your promoter. Professor Rahouma, the sound, yeah, there you are.
So, do you promise to work in accordance with the principle and scientific integrity at all times, to be careful and honest, transparent, independent, and responsible? By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confirm upon you, Dr. Mohamed Rahouma, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive by ordinary mail the degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university as shown by the beadle.
Thank you so much. Thank you so much. Thank you so much. For all
Let
of
me
you.
again congratulate you, Mohamed,
so
for
much.
very nice work you have done. We have done together with support of Professor Gaudino from the Cornell and Maastricht University. I really congratulate you, your family, your friends, your colleagues, and I'm really glad and honored, and I have the privilege to ask Professor Gaudino to provide le laudatio for your achievement.
Thank you, Roberto. Before getting to Mohamed, let me say that it's an extraordinary honor to be here. And this also speaks to the collaboration between our two institutions that has been incredibly productive in the last few years. I am proud and privileged to say that I was a PhD student of Maastricht University a few years ago. And what you have been able to put together with the help and support of Professor Massen and everyone else in Maastricht is nothing short than amazing. So we at Cornell are very privileged for this collaboration and look forward to even more projects together. Now to you, Mohamed. Dr. Rahouma, it's an extraordinary honor, but also a personal joy to give this lecture, to give this laudatio in this day. You and I have met almost 10 years ago. We both moved from across the ocean to the United States, trying to explore new professional opportunity. You were coming from the most famous oncologic hospital in Egypt, and you had a passion in particular for oncology and the surgical treatment of tumors. But then also you had another passion with for data and for epidemiology. You did not have a formal training in biostatistics of epidemiology, but like me, you have learned by trial and error. And then when you had the opportunity, you also were able to get a formal training. I do not know if the other members of the Corona know that Mohamed has also a master's degree in biostatistics that he achieved a few years ago. So I see in you, Mohamed, a pretty unique combination of a physician, someone that is passionate about medicine and in particular surgical oncology, but also with a deep knowledge of epidemiology and biostatistics. And you and I know how many sleepless night we have spent trying to get codes right or to understand data. So this has been a long and common path that we have done together. I'm so proud of what we have accomplished. I mean, you are a deputy statistical editor for our most prestigious cardiothoracic surgical journal. You are involved as a statistical reviewer for the majority of cardiac surgery journal, and there is no doubt that you are now at the top of the field. In particular, your experience and expertise in study level meta-analysis is, as far as I know, unparalleled, and I still learn from you when we perform meta-analysis together. It was not an easy journey. I remember the first years where your family was still in Egypt, and you couldn't see your very young son, who was a few months old at that time, for months, if not years. And I remember all the bureaucratic issue to get a visa to your family and get them to join you in New York, something that was finally accomplished. We went together through the hurdle of the COVID pandemic. Again, we were separated from family because of travel restriction for over 2 years. And there was not a lot to do rather than doing research. Those 2 years were probably the most productive that we can remember here at Cornell, because there were really nothing else to do. Most importantly, Mohamed, you are always generous of your time. It doesn't matter if it is the most junior of the resident or even a medical student asking you for help and advice, you will find the time to help. You will find the time to explain. And this is something that speaks a lot about who you are, not only as a surgeon and as an epidemiologist, but most importantly, as a man. So, in summary, and I can speak on behalf of the entire Maastricht team, but also the Cornell team, I really congratulate you on this very important achievement, and I look forward to a bright future together performing research here at Cornell. Congratulations, Mohamed.
Thank you, Dr. Godino. And it is my pleasure now to congratulate you on behalf of the board of your university by obtaining this diploma from this university. Your name is for always connected to this university. I'm still in doubt whether you ever visited it, but maybe you have never seen Maastricht so far, or have you been here?
No, I didn't. I
You
hope
did
that
not
I
yet
will
visit.
go. Yeah, I hope that I will go soon.
Okay. It is also a pleasure for me to thank all opponents. Normally, I only thank those ones who came from far and who are not working here, but now we are all equal. We were just sitting in our own study or office or whatever. And nobody has to be thanked more special because they had to travel a lot. Having said this, I now conclude, I close this official session, but as we have been asked, stay a bit around or in order to congratulate maybe personally the new doctor. Now I close this official meeting officially. Thank you for being with us.
Thank you so much. Thank you.